So, Ketan Badani, Renu.
Ketan Badani, Declan. He was a great guest.
He was a great guest. So we had Dr. Ketan Badani, urologist from Mount Sinai here in Melbourne.
That's
recently.
right. That's right. He came all the way from New York to visit us and our Epworth Masterclass on robotic surgery.
Yeah, Epworth is a big private hospital institution that we all work at, and they do a really good educational series.
Yeah.
Once a year, there's a particular focus, and this year it was robotic surgery. So, yeah.
And with a particular focus on the single port robot, because it's been launched in Australia this year, and Ketan is such an expert on it. So it was fantastic to get his views.
So for this podcast, we're going to bring you some chats we had with Ketan, and we didn't make him work very hard the whole time. So we took him out to the Yarra Valley. That was a bit of fun, wasn't it?
Yeah, we took him out to some of the wineries in the Yarra Valley. He got a nice glimpse of all of that, and we had some fun dinners in town. And
Australian creatures. He wanted to see Australian creatures.
Especially the ones that can kill you.
Exactly. So stay tuned. We went out to the Yarra Valley with Ketan and we showed him a few Australian creatures, and we sat him down over a glass of wine out there and had a chat about everything from Joe Biden right up to at the end of the masterclass we talked about what is work going to be like in a few years' time. So,
what would you tell your younger self?
Yeah, that's right. So stay tuned. I hope you enjoy this. And if you're watching it on YouTube, you'll see some sights and some creatures from around Australia.
Declan?
Hello, Renu.
Who's he?
Good to have Ketan out here on tour in the Yarra Valley. So he's come down to work at the Epworth Masterclass tomorrow.
That's right.
Great to have you
It's not really work though, is it, Ketan? It's an appearance.
What we do is not work. It's a calling.
He says this at a winery.
But he is here to share his expertise in robotic surgery at the Epworth Healthcare Masterclass tomorrow. And you got a full house, more than 150 of our local urologists
Booked
have turned
out.
up. And
Yeah.
so it's exciting to have you. But for the day prior, the warm-up, we've taken him out here to the Yarra Valley, Renu.
Yes, no, it's been a good day because you love wildlife, marine life, and so we wanted to show you the best that Australia has at the Healesville Sanctuary.
Yeah, I mean, thank you for that. I did want to see Australian wildlife. I think I'd like to spend a month doing that here, but I have 2 days, so we got today to do it. But I tell you what, we made a lot of urology. We learned a lot of urology with the wildlife, right?
Yeah.
And our tour guide was surprised to know we all knew what a cloaca was, because marsupials, many of them have cloacas.
They do, yes.
See? So we learned something, and she learned something.
And we did see kangaroos taking a piss, I think. That was it.
And it was very exciting.
That was very exciting. So it was a urology theme to our tour at Healesville Sanctuary. But that was fun. The wildlife
It was amazing,
great and
amazing. And I think an owl took a little bit off your hair there.
And we are sharing some of that footage with you for those of you watching on YouTube as well. That was fun.
But if you are ever in the Healesville Sanctuary, do watch the bird show. That is spectacular. Yeah. I mean, it is truly amazing. Those tricks are incredible.
Everyone wants to be a zookeeper after watching the way these guys.
It's our retirement plan now.
But so we've left the sanctuary. We're heading to lunch in Jadenong, another of our beautiful little wineries out here, and we're in Rochford Winery here, one of the big wineries in the Yarra Valley, where we've just had a nice tasting with Beatrice, which has been delicious, and we'll pick up some wine. Australian wine is meeting your fancy.
Australian wine's great.
That's fine. Just keep it coming, he says.
Yeah. Is it Australian?
Yeah.
Okay.
Of course.
Good to know.
So what we thought we'd do for a couple of minutes just to pick your brains, because the topic of the week we're recording this is in the US in healthcare, certainly. Actually, it's a break from the chaos of US administration, but it's all about Joe Biden's prostate cancer this week. And I have to say, we've certainly felt it here in Australia, Ketan, and patients are coming in saying, do I have Joe Biden's cancer, or I don't want to end up like Joe Biden, because people understand that it sounds like Joe's got quite a serious health condition. And there's a lot of empathy. I've definitely heard that from my patients. I'm sure you have as well, Renu. So I suppose we just want to gauge your sense of the reaction in the US, public reaction, and to Joe's diagnosis.
Yeah, I mean, as you can imagine, with all of the political news dominating, having our former president diagnosed with prostate cancer is a big part of the news cycle now, and rightfully so. And it brings to light the importance of screening for prostate cancer. That being said, none of us are treating physicians, so we are basing this, at least I'm basing this information on what I read, right? What I hear. I don't know firsthand this information, but yeah, of course, being diagnosed with metastatic prostate cancer is shocking to the country.
Yeah, I mean, I suppose it's difficult to make comments without knowing exact details of the diagnosis. So I think a broader topic of, how we approach prostate cancer in the older population is probably more appropriate. You're right. No, it is a rare situation to have someone present with aggressive metastatic prostate cancer at that age. That's symptomatic. I mean, that presumably is how he was diagnosed. Do you have any? What can we take away from that?
Well, a lot of what we say about prostate cancer can be construed as controversial. So these are my own words, right? But if you go back to the generation before us, the urologists, even before you.
Thank you.
No, but seriously, if you go back into the 80s, early 90s, and you ask a urologist, how was prostate cancer diagnosed? The answer was back pain, right? It was bone metastasis. That's how you diagnose prostate cancer. And then PSA screening and early detection and physical exams, rectal exams, all of that brought that what we call lead time, right? When you diagnose a cancer earlier, down to a point where it's now asymptomatically diagnosed. What happened in the U.S., as you know, is in 2012, our U.S. Preventive Services Task Force came out with a recommendation sort of against screening. And then it was dialed back a little bit to, all right, have a conversation, do what's called shared decision making, which basically means have a thoughtful conversation with someone and decide what you want to do. But now we have Joe Biden, who's, again, back to that symptomatic, diagnosed with metastatic prostate cancer, and here we are in 2025. So we've kind of gone backwards, I think, in terms of how we think about screening for prostate cancer. And listen, just because you're 72, just because you're 82, does that mean you shouldn't be screened? Does it mean you shouldn't be screened if you're 75? I mean, our guidelines, and maybe yours are the same, I'm not sure. They say after 70, you might not need to screen. Yep. But 70 is a number, right? You've seen 70-year-olds who are going to outlive you and me. Right? And you've seen 50-year-olds who probably aren't going to make it because they have heart disease, lung disease, they don't take care of themselves. So 70 is just a number, right?
Yeah, I think you're totally right. And I think that's why people are very shocked about it, though, that, if you take his position as someone who was recently running for president and commander-in-chief of the world's biggest military, I think there's, on the one hand, a sense that probably one might have expected he'd be subject to a higher level of screening. And what we have heard this week at the time of recording is that his last PSA test was in 2014, so it was around the time of all that negative stuff about PSA testing in the US. And he was in his early 70s, and it would not have been unreasonable, perhaps based on what the advice was at that time, to say, well, if his PSA is roughly normal, your likelihood in your lifetime is very low. So I think we can reassure ourselves that he was being probably the same standard was being applied to him as would apply to other men in the US in their 70s. But on the other hand, things have changed, and I think people are very shocked by Joe's situation, Ketan. And do you think, therefore, within that there'll be a sense of older men and physicians looking after older men saying that, well, we probably should have that conversation about if you're in good nick, and although your PSA was normal at 70, I'm happy to have a conversation with you, so you don't. A lot of patients are saying, I don't want to end up like Joe, so yeah, okay, have another PSA when you're 75. Or
yeah,
do you think that's a conversation?
I mean, here's the thing, right? As urologists, we're not the gatekeepers of that screening. So me personally, I always have that conversation. I believe in it. Yeah. We should do screening in men who have longevity in front of them, right? No matter how old they are. But what percent of men do I see and have that conversation with? A very small percent, those that get referred for a reason. Yeah. And then you have pretty much everybody else who's screened by the primary care community, and they're the ones who have to make a decision, right? Is it right to screen or is it not right to screen? And I think we're seeing the pendulum can swing far in the other direction sometimes, and we're going to miss out on patients that could be cured of prostate cancer that end up with metastatic disease. It's a complex topic, but we don't get to see the population at large. We just see the small percent of men that are referred to us.
Or the ones that come in, like Joe, with symptoms, unfortunately. Right. There's still a few percent in Australia, 5%.
And that's another very important point, Declan, I'm going to make, is that, yes, he was diagnosed because of symptoms. Now, what I get from patients is, I have trouble peeing too. Do I have prostate cancer? And let's be very clear. right? Having trouble peeing is not necessarily due to prostate cancer. As a matter of fact, it's a very small reason of prostate cancer. But yes, in his case, the urinary symptoms is what his presentation was. But 99% of men that have urinary symptoms don't necessarily have metastatic prostate cancer. So I don't want your viewers to be confused that they're having a problem peeing. It means bony metastasis. It doesn't. But it brings up an important point, right? In 2014, how old was he? 72, 70s, right? Yeah. Early 70s. So when do you make that decision not to screen someone? Now, yes, someone running for a very important position. You look at corporations that are hiring a new CEO, they get looked at head to toe, right? You got to make sure you're in top shape.
You're in the flying industry. There are certain industries that do call for a higher.
And if it was your family member, right? Would you not want to, make sure that they're in tip-top shape just because it's something that's important to you? And I think if you ask all urologists, and I'm not going to speak for you, but should you screen men if they want to get screened? What are you going to say? I mean, I think universally everyone says yes. But for whatever reason, during that time, it was a heated topic about PSA screening. There was a lot of negative stuff in 2014. So yeah, perhaps there was no screening. 10 years goes by.
That's why I don't think there's much to see here. It's very unfortunate, the whole thing, but people were sort of following a reasonable judge standard of care in 2014, and they probably had a conversation with Joe, and Joe might have said that. We're only speculating. But Renu, I'll ask you that question. So here in Australia, we're about to revise our national guidelines on early detection of prostate cancer, and I'm involved in that process. And one of the big things was the stopping point. People wanted to know, is there a number? And just like you said, Ketan, we've tried to say there's not a number. It's an individual assessment because we have long life expectancy in Australia, and if you have a patient comes in the door age 70, actually when you plug that into a calculator, they've got an 19% a year life expectancy. If you make it to 70, you're going to live to late 80s or 90s, so you have to adjust the patient in front of you.
Exactly.
And what I propose to you, Renu, is that one way we can respond to the allegation that urologists might be overdiagnosing not the Joe Bidens, but many other men in their 70s with unnecessary prostate cancer, is that we do things like MRI scanning. So if you're 74 and you've got urinary symptoms and your PSA is 5 or 6, you're not going to have a prostate biopsy in Australia. You're going definitely 100% have an MRI scan. It's all funded. You're very likely just to find BPH. And so our response is, number one, we're not going to do unnecessary biopsies, unless there's a real signal.
Everyone.
Absolutely. And number two, that even if we diagnose you with a prostate cancer in your 70s, active surveillance or watchful waiting in that age group is very common. Do you think that's a reasonable way?
Absolutely. I mean, I think it's important to have screening programs to be kind of complemented by good, effective tools to reduce unnecessary diagnosis of insignificant disease. But it remains a risk assessment between the doctor and the patient.
Yeah, I mean, I'm going to, again, New Yorker, all full disclosure, I'm going to say controversial things. But I don't understand this concept of overdiagnosis. It makes no sense to me. Now, over-treatment, yes, this makes sense, right? Yeah, there's some finite risks to diagnosis. There's some finite risks to a biopsy. I get that. But the issue is treating someone who doesn't need to be treated. And that's really where, in my mind, we need to do better as a community of treating the right patients. But overdiagnosis? I mean, how do you know if someone has a bad prostate cancer or not unless you have some form of a diagnosis to make an informed decision with? I know it's a public
controversial as promised, Ketan.
Thank you. Last thing I want to ask you about is...
So we wish Joe Biden well, and
we do wish Joe well.
And the other thing is, this is still, although not a curable situation, it's a treatable situation.
Absolutely.
People do well.
He's going to do great.
And men with even metastatic prostate cancer, we know we have long, durable treatments.
And treatments that can improve quality of life.
Yeah.
So that's the important
So I think this will be good.
Yeah.
Although, on the other hand, I hear people saying that. I wanted to ask you finally about the media reaction, all the experts coming out, especially in US media, social media, etc. But people say, he can have hormone therapy and chemotherapy and AR pathway inhibitors, etc. But, a message I would have is, depending on his situation, we always worry about putting older men with a bit of cognitive impairment, sorry Joe, on things like ADT and RPs, because it can definitely affect function a bit. We've all seen that, So I think what I would be saying to people is, yes, we have treatments that can slow up progress here, and we always bounce that off. Can I ask you about that? Older men, because it's tempting. Oh, now he's been diagnosed, let's throw the book at this guy. But we're always trying to balance up the impact of treatment with the impact of side effects.
Yeah, I mean, there's no question that in general, androgen deprivation hormone therapy, what you give for metastatic prostate cancer, has a very favorable side effect profile compared to chemotherapy and some of the advanced, the PARP inhibitors and such. That being said, cognitive impairment is one of those side effects, and you have to think very strongly about someone, and not specific to the former president, just someone who's got a cognitive issue. Do you want to exacerbate that by giving ADT? And maybe you won't. You don't know. But the other thing is you can do intermittent ADT. I mean, there are some options for this. I mean, there's ways to make it palatable for somebody. But yeah, I mean, the side effects are the side effects. And what would you do? I mean, what would you do in this situation, right? You know you could make it worse.
Well, I mean, I think this is where research looking at bringing things like radioligand therapy and lutetium PSMA earlier and earlier into the treatment spectrum or the disease spectrum is really exciting, because, you know, things like lutetium PSMA could be potential future treatment for metastatic hormone-sensitive prostate cancer.
She's the one being controversial now, Ketan. Jeez, you know.
I like it.
Exactly.
Taking my lead from him.
Well, she's the expert.
She's the expert on this topic,
you know?
yeah. So do you have many 82-year-old ex-presidents with cognitive impairment coming on?
Not yet, Declan.
But I want to ask you finally, Ketan, about that. Geez, I mean, the world kind of loses its head with reactions and all, this whole expert industry out there, all sorts of people. It's entertaining to look at, and you know, geez, it's a bit too much sometimes, isn't it?
Yeah, I mean, listen, you know, news is one of those things. When something comes out in our world, whether it's prostate cancer, whether it's kidney, whether it's something with BPH, the news goes crazy, right? Because you think about how many people that disease affects. Prostate cancer affects, in the U.S., 1 out of every 8 men in the right age range. So it's a massive number of people and their families and their spouses. So, of course, the news cycle goes crazy. The problem is, right, nobody is a personal physician of the former president who can speak to his, you know, details. So everyone talks in general terms. Now that I'm going to say is an important thing. Bringing awareness to prostate cancer, bringing awareness to potentially screening men who are over 70, who are going to live long, and there's some value to that, is important. But then hearing, you know, 50 different people have their opinions on, you know, what should happen when we don't know the details of the situation. I mean, it's not fair, you know.
Well, look, I think we could wrap it up, Renu, by reaching over here and getting this nice glass of Cabernet Sauvignon from Rochford, and we could raise a toast to Joe, couldn't we? So.
Yes.
And just, I'm going to make another tie-in.
Oh, yeah.
The animals we talked about
Yes.
has urology tie-in, but red wine has resveratrol
Okay.
and pomegranate. Both are healthy for the prostate. So.
Well,
Controversy.
here we go. Here's the two of us in our prostates.
We're doing our part for today.
Here's to you, Joe. It's the end of the Epworth Masterclass. Ketan, thank you for joining us. Did you have a good day?
Oh, it was amazing. It's great to be in Melbourne.
Oh, you can even say Melbourne.
Melbourne. No, it was full house all day. Congratulations, it was a great meeting.
It was great, and he worked his ass off all day. He was our solitary international guest on this Epworth Robotic.
You put me to work. You put me to work. That's okay.
And you're in Australia for 3 days, so it's hard work. But yeah, look. So I wanted to pick your brains on one thing. So today we talked a lot about futuristic robots coming, and you talked a lot about the SP, which is new for us here. But we talked about the Chinese robots coming and other robots coming. We talked about the impact of AI on decision making and all that. So here's a question that came up over lunch. People were saying, well, what will people like you and I be doing in 10 years' time or 15 years' time? What will a day of work look like if you're a full-time, prostate kidney specialist working in New York? Do you have a sense of what older Ketan will be doing?
I don't know what I'll be doing next Tuesday. Okay. 10 years? No, all joking aside, it's fun and it's exciting to think about the future.
Yep.
You gave a great talk on all the future robotic platforms, and it really makes you think, right? What's going to fit where? This concept of remote surgery, telesurgery, reaching out to a community that might not have access, and then obviously the administrative, social, and political aspects of regulation of that. I mean, it's all just stuff that needs to get worked out. So I'm hoping in 10 years that stuff gets worked out. And on top of that, see, right now, you and I, we do what we can do with these.
Yep.
That's it. We got our hands, we got our mind, and we can do an operation. But I think robots do things better than you and I do. We're just not there yet. So I'm hoping 5 years, 10 years, good parts of what we do are automated, right? And it's scary. Listen, I grew up in Detroit. everything was automated. When I grew up in the 70s and 80s, it was all robots. Robots built cars, right? So we have a good familiarity with robots. And although patients might be skeptical of saying, well, is a robot doing my surgery? You must get that now. Does a robot do my surgery?
Or what if the robot, loses its mind?
Right. But the truth is, robots are more predictable, they're stable, they don't make errors. And so I think we work towards that automation in actual human surgery.
And that's definitely part of the theme of that as we, here in 2025, still at the start of that ChatGPT type revolution where it's still kind of jaw-dropping what large language models can do. But we haven't yet seen it kind of flow widely into healthcare quite yet, but definitely not into surgery. But, as we talked about today with machines like the Da Vinci 5 and those that have like massive amounts of computing power, how will that affect us? It's incredible, isn't it? Whether it's just incredibly detailed knowledge about what's going on in that abdomen or pelvis you're in, or the ability to enhance your treatments with stuff that AI is helping us with, or treatments that can be administered along with our surgery and a lot of automation. I'm sure we're going to see stuff we can't even imagine, like the way we couldn't imagine ChatGPT just recently.
Yeah. Well, automation is 10-year step, but what you're talking about is actually low-hanging fruit, right? Anatomical navigation, image navigation, surgical planning, image overlay. That technology is here today. Now, Da Vinci 5 doesn't have it yet, but it's there.
It's got the capability.
The tech exists, and even the platform to do that exists. All this stuff needs regulatory approval. But think about it. In a year, maybe 18 months, you can have your image on top of your surgical field. Yeah. You can have a computer in Da Vinci 5 tell you that's ureter, that's rectum, that's bladder. And that may seem like a little step, but this concept of democratizing surgery, everyone can do an excellent job on an operation if a computer helps you do it better, right? So you're a master surgeon. Not everyone can do what you do, but now you have a computer that helps other people be as good as you or anyone else who's a master at what they do. And that's the goal.
And that democratization is important because one of the terms in surgery that is disturbing is the learning curve. Because it came up today, the learning curve for erectile sparing surgery, and we talk about it casually. Oh, the learning curve is 50 cases or 100 cases before the positive margins will settle or something. But that's the way we talk about it. But each one of those 50 patients is an individual patient having their only radical prostatectomy, and that surgeon may have been able to achieve this outcome previously with an operation, but now they've got a learning curve. So what does that mean? It means that the results will not be as good as they would be if that patient was 50 cases later. So is that what you're talking about a bit, to say we can reduce some of that and have machines help us a bit, so that learning curve in itself means the individual patient is not going to be exposed to someone's learning curve, or as little as possible?
Yeah, well, that's an important aspect. So it's to say, okay, let's think about a future, not 10 years, 50 years from now, where it doesn't matter where you go to have your operation, you will get the same operation, right? It doesn't matter because it's all automated. Okay, that's futuristic thinking, that's scary, but I think that's realistic. Learning curve is how long does it take you to get to a level of proficiency, but who defined that, right? So when you look at radical prostatectomy data, I go back to the year 2001, 2002, we wrote the first learning curve papers. It was, you need 20 cases to have the same whatever. And your endpoint was readmission rate, or your endpoint was blood loss, or operative time. Operative time was a big one. Yeah. And then it became 50, and then it became 200. There's papers that say you need 3,000 and you're still improving, right? So, at some point, you just continue to get better the more you do of something, and that's just from these hands. You're just doing it. But computers will help you get there and do it reproducibly better, right? So the learning curve kind of goes away, right? You don't have that, I need to figure out how to do a nerve spare. Computer's going to tell you how to do it. It's going to show you where to cut. It's going to show you how to push the nerve bundles. Haptic feedback, right? Da Vinci 5 has haptic feedback. How valuable is that going to be? Well, we don't know. Maybe pushing too hard is a bad thing for nerves, right? You get traction injury on nerves. So Da Vinci 5 could tell you, hey, that's too hard, stop. And it'll stop you from pushing that hard. Even though you want to. You just want to push the whole bundle off the prostate and say, look how beautiful that is, but you've stretched the nerves to death.
Yeah.
Right? And maybe that's bad, and these systems will help us improve that. There's so much to do in this. There's so much excitement around this.
Here's one I want to pick your brains on. So we talked today a bit about intraoperative margin assessment with NeuroSafe, but also with these other technologies that can do intraoperative margin assessment like Histolog. I know you've got a trial getting up and running as we do here.
Yeah.
But isn't that kind of an obvious one? You'd think, oh, surely, and patients will say that, oh, you're in there, you get this great view. Why can't you incorporate that type of confocal microscopy into the view so that as you're doing the nerve spare, not you take it out and you look at it on a machine or send it off to a lab, you can see it surely. Wouldn't you think that, this is surely where we're going? And
I think some of that technology exists today, right? Yeah. It exists today. And it's not just intraoperative margin assessment. You can look at urothelium, right? You can see ureter. That technology exists today. Yeah. The scope can show you where urothelial cells are. Yeah. So for the GYNs, for the colorectals that get very close to it, even for us that don't want to hurt a ureter, you see it. And you don't even need to give an injection to see it. It is innate in this. PSMA, these other markers, that exists too. So that stuff is happening right now. It just hasn't been launched fully and commercially. But then think about other things like looking at cavernous nerves, right? You can see that. You can see the cancer. You see the prostate. Even benign prostate, that would be useful, right?
Yep.
Because you know where you are. You know you're too close. You see benign glands. So all of this intraoperative navigation will coalesce into all of this telling you what you need to do to make it better.
That's why I think, it is interesting and disruptive to see the wave of Chinese robots and those coming, but, they're still kind of based on the Da Vinci systems from 10 years ago, the XI, and okay, now we're 2025, maybe you can get them cheaper, but we need to make progress, we need to have people like Intuitive doing something like the Da Vinci 5 to say, here's a thing that has 10,000 times more processing than the previous version, because we're going to need to incorporate that type of image assistance, etc. So I think it's interesting to see the waves of robots that might help reduce costs in countries that don't get access, but we do need the pioneers and the top engineers to be pushing and have that platform capable of incorporating the technologies that we don't even know yet.
Yeah, well, if you think about it, right, when Da Vinci 5 was launched, and one of the big taglines was, 10 times the computing power, I thought to myself, so what, right? Who cares? Yeah. It's got a better computer. But what you realize very quickly is the XI has capped its computing power. They can't put more software on the XI anymore. And I was talking to the engineers. So if you want to do things like navigation, image overlay, the XI processor cannot handle it.
It's always technology.
And the hardware can't handle any more processing either. So it's hardware and software that are limited. And so now you have an XI that it has just done everything it can do.
Yep.
And that's more than 10 years old, right? 12 years old. So now Da Vinci 5 has a processor that's way more powerful than it needs to be for today's work, but it's got to last 10 years, right? And think about all the AI and all the computing power that needs to go into it to do all the things we talked about. Maybe 10x isn't enough. Maybe that won't even be enough to do the computing that's required.
Now, the last thing I want to talk to you about, because this is fun talking about surgery, hoping that you can still do surgery in 10 or 15 years and, there will still be indications to do surgery. But what about the rest of, being a doctor in a healthcare system, we all have to put up with hospital electronic medical records. We won't name any, but we share a similar one ourselves. Sometimes it just can be a bit of a trudge, can't it? Do you think, by the time we get to 10 years from now, Ketan, it'll be less frustrating trying to just manage the hospital EMR environment, less clicks maybe, more automation, just present the data. Patients likewise not being frustrated with, why don't you have my results, or I did that before, I've been asked that question 10 times already on this admission. Will there be a better environment for us to actually do the non-surgery stuff?
I sure hope so.
I hope so too.
But the way it is right now, the clicks go up by the year, right? So the way it is now, the number of clicks and the amount of work you have to do in the EMR, it continues to go up. It's not going down.
Yeah.
And I'll tell you one thing I've resisted, and this is why, I'll admit it, I've been really delinquent in my EMR work.
Yeah.
Because when I talk to the patient, I still talk to the patient. I have partners and I have colleagues who are looking at the computer, you're the patient.
Yeah.
All right. Well, did you have, talking about your prostate cancer, your kidney cancer, not even eye contact, right? Because you want to get the note done.
Because you have to.
That's not good.
Yeah.
So I don't do that, right? So what happens? Then I got to go back and do all those notes. So I hope there's a revolt. I hope that this gets so bad that medical community just revolts and says this is unacceptable, and it'll get better. But I don't know. I'm not optimistic. Maybe you're optimistic. I'm not optimistic.
And I suffer the same. The inbox on the hospital EMR. I have an automated out of office. Send me an email, or better, write me a letter. Put a stamp on it. I'm more likely to read that than the EMR in message. So there you go. It might improve, or you and me might be turfed out.
Some people, and I'm not one of them, need to zero their inboxes, right? Their emails, their phones, their text messages. I've come to a point I don't feel bad about it. My inbox is not zeroed. My text messages are. My inbox on Epic is so high that people walk by, see it,
oh my God,
and do a double take at it. It's not that patients are getting care. It's that what you should check and what you shouldn't check.
Yeah.
It's the administrative tasks. So.
Great. Well, look, Ketan, thanks for joining us in Melbourne. Great to have had you here, and great to join the podcast and enjoy a couple of days in Melbourne. And we look forward to seeing you around the place again soon.
Awesome to be here. Thank you.
You take care.
All right.
And that's all we have time for on this episode of GUcast. We hope you enjoyed that. Professor Ketan Badani from Mount Sinai in New York. Until next time, we'll see you then.